shortened TPA. First, pain maintenance. Second, the rotation of the upper first molar, and encourage reinforcement, and also intrusion of the upper first molar. And also fifth, traction for impacted incisor and canine. And also we can use this scissor bite correction. Among these, we'll discuss intrusion of the upper first molar. We'll use TPA for encourage management, especially when we extract upper first molar or first premolar, and then we want maximum retraction. So for maximum anchorage, we may use TPA. There are several types of TPA we can see. Usually, we can use TPA like this. The loop direction is backward. However, this time, we may use TPA in class 3 malocclusion. Dr. Satrin used this, and then for intrusion of upper first molar. So the design in TPA in class 3 malocclusion is like this: 2 or 3 millimeters away from the palate. The forward direction of the loop, and we can exercise tongue elevation. Some patient, we can see the indentation of the tongue. So these are main expected change result. Tongue exercise on the TPA, and it means inhibition of the upper first molar extrusion. So it means we can see relative intrusion. So we can see the over eruption of the lower molar. It means steep occlusal plane. So it means inhibition of mandibular forward growth. So through this, we can achieve some inhibition of the mandibular forward growth, class 3 treatment. We can see the erupted lower second molar. On the other hand, the upper second molar are erupting. What happened? Due to the posterior discrepance, and then these teeth pushing the upper first molar, and for over eruption of these teeth. When you use TPA, and finally we can see the vertical height differences between upper first molar and lower first molar. So these are main indications in TPA in class 3 malocclusion. I use TPA in mild class 3 malocclusion for intrusion of the upper first molar. Second, growth observation after first phase treatment. Third, post-treatment retention. We can use this TPA as a retainer, especially before upper second molar eruption and after correction of the posterior crossbite. And also finally, the growth observation in severe class 3 surgery case. This patient is 11 years old boy patient. She complains is H2H5. His profile is not bad, good. Upper canine are erupting, and we can see also lower second molar erupting. This. This patient in PA view and midline match and ramus high symmetry is okay, antagonal large symmetry is okay. However, frontal view and there are some shoulder difference. ODI 60, APDI 93. This means class 3 high angle case. His profile is good. This patient is APDI 93. This means skeletal class 3 malocclusion. Upper incisor angulation upon to FH 118. This is slight labial version of the upper incisor. Lower incisor, lower onto mandibular plane 83, lingual version of the lower incisor. Treat now or wait. When you treat now, these are possible potential problems. The labial version of and crowding of the upper incisor. So this means the upon to FH 118 may worsen. And also we can see lower anterior spacing. However, IMPA is 83. When you treat this and then it takes longer duration of treatment. What happens if we are waiting? Nowadays, this under eruption of the upper second molar, it may cause posterior discrepancy. So I want to check this. This is maxilla. Some case we want to maxillary for the movement. This time checkpoint is edge to edge by profile is okay. And A point to lesion perpendicular line 0.0 millimeter is normal. Maxillary dentition upon to FH is, if this value is lingual version, we can achieve anterior crossbite through labial version. However, this patient is almost normal rather than labial version. Third part, mandibular dentition. At that time, I want to check lower to mandibular plane angle. 83, this is lingual version. Fourth, mandible. This patient showed edge bite and low shape value. These are possible treatment plans. You can see that there is a space in the lower arch. So when we close the space, and we can achieve something. Second fact, treatment plan is TPA in the upper arch. In this patient, and upper canine are not erupted. So I want to insert TPA at first, like this. 8 months later, and we can remove the TPA and reinsert like this. And every year I check this, and finally we can see that this patient upper second molar are fully erupted. These are superimposition from pre-treatment and then after growth. This patient, instead of inserting TPA, we do not apply conventional brace treatment. This patient is 10 years old, female patient. She came to my office due to edge-to-edge bite and anterior crowding. She is Hellman Dental age 3B, mixed dentition exchange period. In PA view and midline match, however, right side, ramus height is longer and antagonal latch is, there is some differences between left and right side. ODI 72, APDI 89, class 3 low angle. APDI 89 means skeletal class 3 malocclusion. This patient, combination factor is 162. This means class 3 low angle case. Upon to FH 119, this means labial version of the upper incisor. Lower incisor, low 1 to mandibular plane angle 105. This is a labial version of the lower incisor. Treat now or wait. This patient is especially low 1 to mandibular plane angle 105. And also we can see edge to edge bite. This patient, we may use expansion arch wire. We can see some posterior crossbite this area. If we want to align lower anterior teeth, what happened? We can see the more severe anterior crossbite. Till now, these are main problems. The labial version of the upper incisor and lower anterior crowding and protrusion. She has Hellman Dental age 3B. Wait, the posterior crossbite is main problem. I think this patient, for this patient, there are two options. One is upper slow maxillary expansion. And also somebody may use in the lower arch, lingual arch, and alignment and retraction of the lower incisor. In Myo, we emphasize the tongue position, especially in class 3 and open bite malocclusion. If we use SME, and I think it may cause lower tongue position. Other method, we may use TPA in the upper arch. So we insert upper arch, TPA in the upper arch. And we are waiting for exchange of the buccal teeth. Almost 15 years, and we can see some crowding in the upper and lower arch. How about the profile? not bad, good. This superimposition of this patient. This photo is pre-treatment to frontal view and after inserting TPA. And then we check everything. Combination factor is 162. 62. This means class 3 low angle. And upper to FH 121. Lower to mandibular plane angle is 97. Inter-incisor angle is 118. However, this is E-line. Her profile is not bad, good. So we'll insert the brace in the upper and lower arch and upper 16 night trial in the low mule. And we use triangular elastic and we insert the upper and lower mule and we used anterior vertical elastic from upper first loop, lower second, first loop, and finished. In mule, the treatment procedure is very, very simple. Strategic leveling and inserting mule and finish. Okay. This is a post-treatment to PA view and frontal view. Okay, look at this. The treatment duration is 11 months. How about the CF value? Low angle does not change into high angle, stayed low angle. How about the upper to FH? 121 remained 121. Okay, like this. This is pre-treatment photo and after inserting TPA and this is post-treatment photo. How about the profile? Okay, like this. Look at this patient. We can see the anterior crossbite with deep bite. How about in the low arch? There is no crowding. And in the upper arch, we can see the slight crowding in the upper canine area. This patient is the end of Hellman dental 3B stage. ODI 63, APDI 95, class 3 low angle case. How about the profile? We can see the protrusive rib and slight posteriorly positioned maxilla. This patient, APDI 95 means skeletal class 3 malocclusion. How about the upper 1 to FH 116? This is normal. Lower to mandibular plane MP angle is 90. This is also normal. This patient, you can see the protrusive profile in the lower jaw. And a point to lesion perpendicular line is 2 millimeter backward. So this patient, we want to increase anterior vertical dimension. And also, using face mask, we want to achieve maxillary forward movement like this. So in order to achieve this, I want to use posterior bite block in the lower arch. This is upper arch, labiolingual arch. Next week, we'll, sorry. The rest day, we'll discuss about the face mask and also this in detail. This time, you should remember this. In the lower arch, we may use posterior bite block. This is face mask. This is August. In November, we can achieve this proper overjet. After correction of anterior crossbite, how can we maintain this kind of malocclusion? So in December, I want to remove the whole appliance. We can see the class 1 molar relationship. During this time, we can achieve some see the maxillary forward movement. At that time, after jumping out and crossbite, we may observe without any appliances. However, you can think you may use TPA because of a posterior discrepancy in class 3 malocclusion. So this kind of TPA is some kind of retainer. So I want to insert TPA in the upper first molar area. So in Myo, we want to erupt the lower second molar. So we are waiting these teeth. So 1 year later, however, you can see there is no eruption of the upper second molar. And we can see the erupted upper second molar. I suggest to this patient to continue orthodontic treatment. However, she and her parents refused. This patient is a 7 years old male patient, anterior crossbite. In the lower arch, slight spacing in the lower arch. This patient is Hellman Dental A3A. So I want to insert posterior bite block in the lower arch. This is upper labiolingual arch with hook. However, this time I should have used this type of appliance in the low arch instead of bracket. However, it doesn't matter. So after correction of anterior crossbite, I want to insert TPA in the upper first molar area. So we are waiting for exchanging of the buccal teeth. After eruption of the exchanging of the buccal teeth, we did re-diagnosis. How about the profile? Not bad. Finally, we'll do this non-extraction treatment, this patient. The next day, we'll discuss about this patient in detail. These are post-treatment photos, 43 months later. This patient, 13 years old girl, and we can see the severe anterior crossbite and mandibular prognathism, class 3 deep bite. In the lower arch, there is no crowding. And also in the upper arch, there is no crowding. Especially in the left side, and we can see the severe class 3 malocclusion. Even though this patient has severe class 3 malocclusion, we can achieve this without surgery. Her profile is improved. How can we retain this kind of malocclusion? These are retention methods after posterior crossbite correction. We may use a removable appliance. Some case we may use a wrap around retainer or a Holy type retainer. I think these are main potential problems. Difficulty in full-time wearing, it may cause lower tongue position and also narrowing upper arch. In this case, we may use TPA and lingual arch in the upper arch. This is a fixed type retainer. These are main problem is the calcifications or dental caries. So this patient will insert like this kind of retainer and 16 years old. And this is post-retention 24 months later, and we can remove this TPA and lingual arch. This boy is 10 years old. He came to my office, anterior crossbite. How about his profile? We can see the protrusive lip. And also we can see the edge to edge bite. In the lower arch, there is no crowding. In the upper arch, there is slight crowding in the upper arch. In the PA view, midline and everything is okay. In hand wrist radiograph, we can see this patient. This is peak high velocity. This means this is a stage 4 and 5. This is a high growth potential. This means greater change in profile and dental change. On the other hand, stage 6 or 7 and low growth potential and less change. However, his stage is stage 3. And this time, ODI 59, APDI 93, class 3 high angle case. And also we can see the protrusive rib like this. APDI 93, this means skeletal class 3 malocclusion. Upper onto FH 115, normal. Lower to mandibular plane angle 87 is normal. However, we can see the protrusive rib. So these are checkpoints. The profile is protrusive rib, and you can see the edge to edge bite and low shear failure. In our hospital's study, this is a stability prediction of class 3 growing patient. We consider severe anterior posterior crossbite. This means anterior posterior problem. We consider this is main relapse factor. However, our study shows the vertical problem is the main causing factor for relapse. So as you know, this is a palatal plane, this is mandibular plane, this is AB plane. We can draw the sum line from PNS in parallel to this AB plane. This is called PL line. This is 20 years study, years ago study, and then so we can draw like this. This is a PNS and perpendicular line to the mandibular plane. This is called MPPP. And also this line is palatal PNS to perpendicular line to the mandibular plane. So at that time, I want to know the posterior part clearly. So at that time, the scale we want to discriminate between stable group and relapse group. The AB to mandibular plane. Greater than 61 is stable group. ODI 65, anterior length. This is maybe ratio like this. And his data, relapse factor is 8.8. Whole factors after treatment, after correction of the anterior crossbite, this patient showed relapse. So this patient, these are main problems in face mask therapy. Worsen longer face, and also worsen labial version of the upper incisor. And also you can see worsen protrusive ribs. It means later we needed extraction treatment or surgery combined orthodontic treatment. These are main problems in no treatment, waiting. This patient is MP3 equal stage in hand-wrist radiograph. This means high growth potential and worsen mandibular prognathism. So it may increase surgery. So I think there are two possible treatment plans. First, maxillary protection. Second is TPA. However, maxillary protection appliance treatment can cause relapse. So I want to insert TPA and wait, like this. This time we can see unerupted upper second molar. It means erupting upper second molar can cause upper first molar over-erupting. So this is called posterior discrepancy. So I check this. I'm 15 years old, and we can also check this. How about the profile? Not bad. Like this. During the growth, we can superimpose the radiograph. This time, I want to check two things: facial aesthetic. Second factor is canine relation. This patient is canine, the tip of the upper canine, where is located the lower first premolar. This is FACC line. We can see the medial side, this side. So this is called half class 3. Half class 3 is when we are using mule, half class 3 is effective. On the other hand, full class 3, this means upper canine is located in this area. It is ineffective in mule, using mule. And also, I want to check the facial aesthetic. So this patient, facial aesthetic is not bad, and we can achieve this. We can achieve good result with this patient. So as you know, this is a posterior discrepancy. And during this time, I missed this, the management of the transverse dimension. So we allow expansion of TPA. And also, we should control upper second molar eruption. So I want to modify TPA design like this. As you know, this is a transpalatal with TPW, shortened TPW. After eruption of the upper first molar, the distance will grow and increase like this into 35 millimeters. So after inserting TPA, and we should allow upper first molar expanding. And also, these are potential problems in using TPA. Some case we can see the calcification of this area. So these are solutions. We may use this appliance short period. And also, I want to re-cement TPA every 6 or 10 months. I did. At that time, I want to TPA expanded the state 1 millimeter like this. So these are main indications in TPA in class 3 malocclusion. First, mild class 3 malocclusion for intrusion of the upper first molar. Second, gross observation after first phase treatment. So after correction of anterior crossbite and jumping out, and during the growth, and we may use TPA. Third, post-treatment retention appliance, especially before the upper second molar eruption and also after correction of posterior crossbite. At that time, we may use TPA and lingual arch. And four, gross observation in severe class 3 surgery case. So the basic idea in using TPA is how can we assess the upper first molar condition in Myo. You should remember the over eruption of the upper first molar is the main key factor for class 3 malocclusion. So we should control these teeth. So intrusion of the upper first molar. So these are main mechanics in TPA. Tongue exercise under TPA. So this means relative intrusion because of tongue force, and then you can see inhibition of the upper molar extrusion. So during the growth, and what happened? So we can see the over eruption of the lower molar. So this means stiffen upper occlusal plane. So it is good for class 3 treatment. So we can achieve inhibition of mandibular forward growth. So this kind of TPA we may use before after treatment. So active treatment is maybe after lower second molar eruption period. So before then, we may use TPA. And also after active treatment, and we may use TPA as a retainer. Okay, we may use TPA, especially in molar derotation or anchorage management. However, in class 3 malocclusion, in order to control the upper molar over eruption, we may use TPA. Okay, this is Incheon Bridge, and then this is beautiful place. Okay, we 10-minute coffee break. Okay. Okay, let's move on to another topic. Posterior bite block with anterior coverage, shortened PBBA, and resin overlay. Earlier we mentioned these. The class 3 etiologic factors, extrusion of upper molar and decreased anterior vertical dimension. And so the treatment strategy in early orthodontic treatment, intrusion of the upper first molar and increase anterior vertical dimension and over eruption of the lower first molar, and also coordination of upper and lower arch. Among these, this time we'll discuss this from 2, 3, and 4, these factors. We already mentioned this, intrusion of upper first molar. Second factor, increase anterior vertical dimension. In order to achieve this, we may use this kind of this kind of appliances. So anterior ABP, anterior bite plate. However, in class 3, we cannot apply this appliance to the class 3 patient. Second is posterior bite block without anterior coverage. Third, posterior bite block with anterior coverage. And also functional appliance, and this is a resin overlay in primary molars. So third factor is extrusion of the lower first molar. How can you achieve this? Through crest elastic, especially long crest elastic. However, in class 3 treatment, we cannot apply this kind of force. Also, anterior bite plate and utility arch wire. And also, it may cause reversion of the lower incisor. First factor is resin overlay. And also, first, especially in the narrow upper arch, we want to expand the upper arch. So this means coordination of upper and lower arch. These are treatment duration for first phase treatment. Especially in class 3 deep bite. This is class 3 open bite. Which one is severe? Class 3 deep bite. However, the treatment complexity this is lower. So this is a simple case or complex case, especially functional class 3 and dental class 3, and also class 3 low angle case, we can achieve good result, even though the patient has shows class 3 deep bite, severe anterior crossbite malocclusion. There is no royal road to the early orthodontic treatment. In theory, we should choose the best way of treatment. considering patient discomfort, treatment duration, and treatment results. So this time you should remember this class 3 deep bite. Somebody want to treat this malocclusion without increasing anterior vertical dimension. So what happened? In order to correct anterior crossbite, it may cause trauma from occlusion in the anterior area. So limitation of maxillary forward movement, and also some case we can the greater amount of forward movement is needed. So it means longer treatment duration. So in this case, in class 3 deep bite, we want to increase anterior vertical dimension like this. So some case, we want to put maxillary forward movement using face mask. Some case, we want to make maxillary anterior dentition forward movement, some kind of spring or expansion plate. And also, some case, we want to mandibular retraction of in the lower arch, this area. So the first thing in treating class 3 malocclusion is increase anterior vertical dimension. This is a popular approach to increase anterior vertical dimension. We may use lots of appliance. This is PBB, PBBA. This is resin overlay. We may use functional appliance. I want to emphasize, especially discriminate through this appliance based on the lower tongue position and also patient discomfort. Through functional appliance, we may achieve some good result. However, it may cause some lower tongue position, and this is bulky, so also longer treatment duration. So nowadays, I do not use functional appliance for class 3 early orthodontic treatment. So I want to emphasize these two appliances. So at that time, this is PBB in the upper arch or lower arch. The purpose is to increase vertical dimension. When you use PBB in the upper arch, we consider intrusion of the upper molar, so it is good. However, the main problem is it may cause lower tongue position. And also, some case, the intrusion of the upper first molar is good for class 3 treatment. However, through this resin plate, it may cause some mandibular backward or forward movement. So for me, I want to PBB in the upper arch. There are two appliances. So this is banded RME, rapid maxillary expansion, and also SME and plus PBB, like this. On the other hand, when you use PBB or PBBA in the lower arch, what happened? Intrusion of the lower molar and also extrusion of the incisor. So intrusion of the lower molar is not good. However, in using this appliance in the lower arch, we can achieve tongue elevation effect. And also, so increase in vertical dimension this area, we can achieve mandibular backward movement. However, in order to treat class 3 malocclusion, we need two appliances. So when you use PBB in the lower arch, we may use RME in the upper arch. When you use resin overlay, which one is better in the upper arch or lower arch? So when you use resin overlay in the upper arch, it may cause mandibular forward movement. So it is good for class 2 treatment. On the other hand, you should remember, when we want to treat class 3 malocclusion, we should insert resin overlay in the lower arch. So this is a treatment strategy. Especially we can see the class 3 deep bite in first phase treatment. Among these, and then especially two, extrusion of the lower first molar, we can achieve this through resin overlay. And also, we want to increase anterior vertical dimension, especially in class 3 deep bite case. We may use PBB or PBBA. As you know, this is a lower primary second molar. Primary second molars resemble secondary first molar. So we should make permanent first molar shape. So these are main indications for resin overlay in class 3 malocclusion. First, in mild class 3 malocclusion, to increase anterior vertical dimension and for eruption of the lower first molar. Second, after jumping out using PBB, and we can see the temporary posterior open bite. At that time, we may insert resin overlay in the lower arch. And also thought synergistic effect with the TPA. This patient is 60 years boy patient. You can see the extrusion of the lower incisor, and this is curve of P, excessive curve of P. Okay, this patient, APDI 84, this is class 1. The class 1 lower angle case. So this patient is dental and functional dental-alveolar class 3 malocclusion. Upon to FH 105. This is a lingual version of the upper incisor. Lower to MP 88. This is normal. So the main problem is upon to FH 105. However, we can see this excessive curve of P in the lower arch. So over eruption of the lower incisor and forward position of the chin and over eruption of posterior facial height and undergrowth of the maxilla. So it may cause undergrowth of the maxilla, class 3 malocclusion. So These are possible treatment plan. First, anterior expansion plate. So anterior expansion plate is will incorporate screw in this area to move the anterior teeth forward. At that time, you should insert the posterior bite block this area. However, these are main problem, not yet erupted upper incisor. So it may worsen deep curve of P. So second case is SME, slow maxillary expansion. Third, region overlay. So plan A is I want to insert region overlay or region overlay and SME. So I want to insert region overlay in the primary first and lower, second molar. And you can see this flat curve of P, flat curve of P. And we can change the occlusion like this. After inserting the region overlay in the low arch, and we should check the eruption of the remaining teeth. Okay, I did. So we can see the backward movement of the low jaw and okay, like this. So region overlay on the lower primary teeth, molar area, like this. These are expected change. So increase the vertical dimension and may place the tongue first under this area, and second is mandibular backward rotation due to bite raising. So this means an over eruption of the lower first molar. It may establish class 1 molar relation. And finally, we can achieve proper overjet and overbite. At that time, we have the following question. How much resin thickness? So edge to edge bite in anterior area. When to remove? Do not remove the resin overlay after correct jumping out. So this resin overlay is exfoliated with primary molar teeth. The common problem is the easy detachment of resin overlay. So some case we may resin overlay with tooth prep. Originally we do not prep the teeth. Some case we may use blue resin like this. This patient, you can see this. How about the upper arch? You can see the normal arch. His profile is not bad, good. So at that time, we insert resin overlay like this in the lower first and second molar area. At that time, we can see anterior open bite. So you should notice the patient that do not thrust the tongue anterior this area. And then During the eruption, and we can see the proper or overjet relationship. Okay, this patient is 7 years old girl patient. We can see the anterior crossbite. How about her profile? Slight protrusive rib in the upper rib, this area. There is no crowding in the upper and lower arch. And midline match and rim's height and antagonal archmetry is okay. APDI is 81. This means class 1. So this patient is dentoalveolar class 3 and upper incisor upon temperature 103 lingual version. Low 1 to MP 89 normal value. So this is a posterior bite block with the anterior coverage in the lower arch. And this is a two expansion with the hook. The next day we'll discuss this in detail. This is face mask. In December and February, I insert resin overlay like this. Somebody want to use face mask longer. However, what happened? Longer usage of face mask. I think much more protrusive ribs and longer face. However, this patient, you can see some detachment of this resin overlay. So I change the blue resin in clinic. And during the growth, and then we can see the proper overjet. And however, we can see some anterior crowding in the upper anterior area. How about her profile? Not bad. However, still protrusive rib this area. When you treat class 3 malocclusion, I want to emphasize the position of primary canine relation. For anterior-posterior relation, if the patient shows class 3 primary canine relation, it may cause skeletal problem. If there is a crossbite and we need expansion or grinding, and also we can see the pointed canine tip, and we should grind the point this area. The more class 3 deep bite, the higher possibility of mandibular backward movement. This means the greater space in the posterior area. So some case, after jumping out, especially in using posterior bite block, we may see the posterior open bite like this. At that time, we want to good settle in this. However, some case, you can see the relapse like this. So many orthodontists use the face mask longer. However, in clinic, it is not easy to achieve this kind of tooth or maxillary movement. So this time we may insert resin overlay this area. So at that time, lower second primary molar retention is good treatment to timing. Look at this patient. You can see after using face mask. However, it is not easy to achieve proper anterior overjet relationship. So I will insert resin overlay like this longer. What happened? While using resin overlay, we can see the over eruption of the lower first molar area like this. And finally, after exfoliation of the lower second primary molar, and we can see the class 1 normal relationship. So these are treatment strategy in class 3 malocclusion. Especially, we want to focus on vertical problem. However, some case we can see the transverse problem. Transverse problem is, and we may use expansion appliance, like rapid expansion or slow expansion. So in class 3 deep bite, especially in the excessive curve of speed in the low arch, what happened when you use PBB in the low arch? The worsen over eruption of the lower incisor. So this means, and you should change the lower appliance, like posterior bite block with the anterior coverage. It is similar to splint. However, this is no indentation and flat surface. So this is PBB or PBBA on the lower arch. So it may cause the move the mandible backward. It is good for class 3 treatment. Some case, we may use expansion appliance in the upper arch. And also some case, we may use expansion of appliance in the upper arch and face mask in order to protract the maxilla forward. As you know, when you use the expansion appliance, because of the resistance on the pterygoid plate, and then so we can achieve the forward movement of the A point. So expansion, this means an anterior displacement of A point, and add it after using face mask, and then we can achieve greater anterior displacement of A point. So for expansion appliance, we use screw. So in rapid expansion, we may turn once or twice a day. In slow expansion appliance, we may turn twice or third per week. So these are comparison between slow and rapid expansion. We all know this. So slow expansion is more physiologic, however, the mainly orthodontic effect. So, however, it takes a longer treatment duration and also it may use at any age. Dr. Hicks reported that at first, rapid expansion is the greatest skeletal and dental change. However, the post-retention, the net result is almost the same. So as you know, this is a rapid maxillary expansion. There are two types. This is Haas, this is Hyrex type. Haas is, there is a resin part on the palate. Expansion effect is greater in Haas type than Hyrex type. However, for hygiene, Hyrex type is better. So because of this, and then I will use Hyrex type expansion pliers. This is a Hyrex type. So we may bend tooth number 4 and 6 and extension arch wire like this. The arrow direction is posteriorly. We all know this. This is banded RME with hook. This is posterior bite block in the posterior part. This is two expansion of pliers. There is no bend tooth number 4, only tooth number 6 bend and Hyrex type. The effect, the banded RME is greater intrusion of the posterior part. And also, this is a comparison of skeletal and dental change between 2-point and 4-point rapid palatal expander. This is Hyrex type. Lemparski said, and the 2-point appliance in arch perimeter and effects on the mid-palatal suture and the dentition did as did the 4-point appliance. It might therefore be considered instead of the 4-point appliance to successfully produce an adequate skeletal and dental expansion. So I'll use two expansion appliance instead of Hyrex. When you use banded RME, these are main problem. After using, we can see some poor oral hygiene, difficult to clean this area. So I want to differentiate using banded RME and before eruption of the upper first molar and after that. When you consider expansion of appliance, you may think this appliance, the banded RME. The main problem is dental caries on upper permanent molar. Second, banded RME without tooth number 6. So this means an over eruption of the upper first molar. And also Hyrex. At that time, and or first two expansion, rapid expansion. When we want to this type of expansion appliance, we should use lower posterior bite block or posterior PBBA in the lower arch. Or some case, the hybrid Hyrex type. in combining mini screw and expansion. However, I don't like this kind of surgery in younger patients. In class 3 patient, at that time, you should check the profile at edge to edge by. And at that time, if the patient has lower second primary molar retention, excessive curve of speed, we may use PBB or PBBA. Also, if the patient has a narrow upper arch and posterior crossbite at that time, so these are common appliance I want to recommend it. Upper banded RME. Second, lower posterior PBBA and upper RME. Third, upper SME with PBB. After using PBB or PBBA, we may change and or resin overlay. So these are main expansion of plans for early orthodontic treatment. I already mentioned that we should check the lower tongue position. So banded RME is the lowest. And also the banded RME or two expansion appliance, we can edit the face mask therapy. So this means in severe posterior crossbite, we want to use banded RME or two expansion appliance. However, in mild posterior crossbite case, we may use SME or PBB. So in Myo, compared to other technique, we need to use expansion appliance lesser. So if there is a posterior crossbite in the first molar area, so this means the first molar is the terminal molar. At that time, we may use RME and or narrow TPW, and we may use RME. And then before eruption of the first molar, we may use banded RME in the upper arch. After eruption of the upper first molar, I want to change it like this. Upper two expansion appliance and PBB in the lower arch. However, some case we can see the posterior crossbite in the primary dentition C, D, and E at that time. This means in no posterior crossbite in the first molar area, we may use SME. Regarding mild anterior crossbite like this, we can see the anterior crossbite, but class 1 canine relationship. We can see the class 3 open bite. Some case class 3 edge bite. Some case we can see class 3 deep bite. In class 3 open bite, so this patient the patient has protrusive ribs. The profile is not good. So we may use TPA and tongue clip. In class 3 edge bite, we may use TPA. In class 3 deep bite, we may use resin overlay. So this is the TPA with the tongue clip. TPA, the roof is directed forward, and we insert the tongue clip in the upper arch. So after eruption of the upper first molar, If the patient has grade 3, you may think TPA on the upper first molar area. Second is retention of lower second primary molar is good. So you may insert resin overlay this area. However, some case, we can see extraction of the lower second primary molar. So difficult to insert resin overlay in permanent dentition. So this means we need observation. So we are waiting for lower second molar eruption. So this is summary of the problem list and solving in class 3 deep bite. If posterior crossbite, we may use RME. So there are two types, bonded RME, and second is PBBA in the lower arch, RME in the upper arch. If we want to face mask, and we may insert with hook. Second is narrow upper arch, we may use SME or RME. When you use SME, we should insert the posterior bite block in this area. If the patient has excessive curve of SP, you should think PBBA in the lower arch. If the patient has primary second molar retention, you should think resin overlay in the lower second molar, primary molar area. And if there is a crowding in the upper anterior area, I want to use brace in the upper arch. If there is a space in the lower arch, we may use PBB with hook for retraction of the lower incisor. Next time, we'll discuss this in detail. So next week, we'll discuss class 3 differential diagnosis. Second, and maxillary and mandibular dental problem. How can we treat this? It is simple. And also 22nd and skeletal class 3 problem and face mask. How can you treat and apply face mask? And also, and in severe class 3 malocclusion, and we can use face mask and combined fixed appliance. Thank you for attention. See you next week, okay?